aneurysms. Now, this is something that you'll see in the clinical setting, either because a patient will have a history of one or they'll present in an emergent situation because of it. So, an aortic aneurysm is a dilation or outpouching of the aorta caused by a weakened medial layer of the vessel wall. So, when that medial layer gets weakened, any kind of high pressure or volume can actually cause it to balloon out, like what you see here. Now, what artery in the body is under more pressure than the one the heart pumps directly into, right? So the aorta has a tremendous amount of pressure and volume pumping through it, way more than any of the other arteries in the body. So then imagine adding hypertension to that scenario. A weakened medial layer plus higher pressures means more dilation and even weaker walls of the vessel. Now, in the aorta, they're classified by location. So you have a thoracic aortic aneurysm, or a TAA, that typically are located above the diaphragm. And then you also have the abdominal aortic aneurysm, most commonly known as the AAA, which would be below the diaphragm. As you can imagine, though, the highest pressures in the aorta are going to be right here where the heart pumps directly out into the aorta. And so this is a really common spot for thoracic aneurysms. Now, there's 4 different types of aneurysms based on their shape. First is fusiform. This means that it involves the entire circumference of the vessel, just like what we saw on the last slide. And the second type is called saccular, which means it's just an outpouching on one side of the vessel. So the problem comes in when we start to see blood flowing through these under high pressure. And so when it gets to this outpouching, it starts to whip around within that outpouching, and it causes turbulence and high velocity flow in that area. So of course, higher velocity flow means more pressures within that area. The third type of aneurysm is a little different. It's called a dissecting aneurysm. And what happens is that this pressure is so high that it actually causes a tear in the medial layer of the vessel and causes it to start pulling away from the outer layer. So when that happens and the blood flow starts to come in to the artery, it actually gets diverted and it gets stuck here in between the medial layer and the outer layer in what we call a false lumen. And it starts to just pool and gather here. So if all the blood's coming in here, there's much less blood actually getting past that spot. So you're going to see decreased perfusion. These patients tend to have much more severe symptoms because of the lack of flow beyond it. And also they're at higher risk for rupture because of this extra pressure between these layers. Now, the last type of aneurysm that you'll see is something called a false aneurysm. And what that is that when we look on a CT scan or a chest x-ray, for example, we're going to see what looks like an aneurysm. But as it turns out, it's actually just a blood clot that has formed on the outside of the vessel. But the blood flow through the actual lumen of the vessel is intact, and there's not actually any perfusion issues. So can you already see some of the issues that these patients are going to have based on this lack of flow? You're going to have perfusion problems, maybe some pain because of the pressure on the weak walls. And then, of course, you have this high risk for rupture. Now, smaller aneurysms may not be symptomatic, but you'll still be able to see them on a CT or an ultrasound. The larger the aneurysm, the more symptomatic and the higher risk for rupture. So what's the difference in presentation between a thoracic aneurysm and an abdominal one? Well, if this is your heart and here's your aorta coming off, and then about halfway down, you've got your renal arteries going out to your kidneys, and then the abdominal aorta continues down. So if we have a thoracic aortic aneurysm here, you'll see this pain that radiates to their chest and their abdomen and their back, and then sometimes their shoulders. Okay. Now, depending on the size, it can also increase pressures in the thoracic cavity, and it can cause shortness of breath or even chest pain. So then for abdominal aortic aneurysms, the cool thing is you can actually see and feel pulsations of that artery in the abdominal wall when the patient's lying flat. You can also hear what's called a bruit over the abdomen. What you're hearing is that turbulent blood flow whooshing around in here. It's like a whooshing sound that you'll be able to auscultate with your stethoscope. And then the other thing is, if they have ruptured, you may see a hematoma on their flank because of the blood pooling back there. Notice how important it is here to do a thorough abdominal assessment. You need to inspect, you need to auscultate, you need to palpate. And then, of course, like we mentioned before, with any aneurysm, there's a possibility of signs of decreased perfusion anywhere distal to that aneurysm, of course, depending on the size and severity and the location. Now, the most severe risk with aneurysm is that that weakened blood vessel wall can actually rupture. So remember, this aorta is under super high pressure. There's a tremendous amount of volume in here. If this thing ruptures, this patient's going to be in big trouble and could bleed out very quickly. So they would actually need to go to the OR immediately. So signs of rupture would be sudden, severe onset of pain. Again, that pain might radiate to the abdomen, it might radiate to the back, possibly even the flank or the groin. And again, if it's higher, maybe to the shoulder. And of course, because blood flow is compromised, you're going to see signs of shock. Now, you'll learn more about shock in the coming lessons, but essentially, shock is a state where the vital organs are not getting oxygenated blood flow. Okay, so you see cardiac output drops, you'll see blood pressure drop, you'll see the heart rate increase to try to compensate. And then, of course, you'll see signs of poor perfusion. So you'll have decreased pulses, their skin may be cool and clammy, and they might be pale. Okay, they're going to be weak, and you might even have a decrease in LOC or some confusion because of decreased perfusion to the brain. So the number one thing we can do for a patient with an aneurysm is manage their blood pressure. The goal is to decrease the pressure that's put on that weak vessel, but still have a sufficient map to perfuse the rest of the body. Usually that means we want a map greater than 65, not much higher than that, because then we can cause more pressure. So of course we'll use the normal things like beta blockers, or we can use ACE inhibitors, just depends on the patient and what's appropriate for them. So there's only really surgical options when it comes to repairing or fixing aneurysms. One option they have is to literally open the patient's chest, go in, resect the weak part of the vessel, and close the aorta back up. Or they can do what's called an EVAR, or an endovascular aneurysm repair. What they do is go in through the groin, they insert this catheter, and they deploy this graft. The goal with the graft is that the blood flow would now go through the graft instead of putting pressure on the weak vessel here. So that way it doesn't rupture, doesn't get worse. Either way, with either of these procedures, we want to make sure we assess pulses distally. So we're going to especially assess pedal pulses. We also want to assess vital signs and monitor hemodynamics in case they may have a rebleed or anything like that. We're going to monitor renal function. So that would be looking at urine output as well as BUN and creatinine lab values. And then we want to monitor that incision site to prevent infection or other complications. Usually we'll have the patient splint when they need to cough or take deep breaths. That protects them from dehiscence or evisceration, but it's also much more comfortable. So as with the other lessons, there's a care plan so you can see detailed nursing interventions and rationales. But here are the top nursing concepts for aortic aneurysms. Perfusion, perfusion, perfusion. No, seriously, this is a massive perfusion issue, and that has to be your top priority. Yes, they may have some pain, and so you can focus on comfort. They may also have clots or bleeding, so you could consider clotting. But I really want you to think perfusion, perfusion, perfusion. So we need to check the abdomen for pulsating masses. We need to check all the peripheral pulses. And we, of course, need to watch our hemodynamics. Perfusion is a top priority for this patient. So let's recap. An aortic aneurysm is a dilation or outpouching of the aorta because of a weakened medial layer and high pressure. That weakened vessel plus high pressure gives you that turbulent flow and that high risk for rupture. The classic symptoms are pain that radiates to the back. You'll be able to hear and feel the aorta pulsating in the abdomen. And then you'll also see signs of shock because of that decreased cardiac output. Our number one goal is to control blood pressure so that we can decrease the pressure within the aorta to prevent any kind of worsening or rupture. And then if the cardiac output is compromised or the patient's high risk, we're going to repair either through an open surgery or an endovascular aneurysm repair. And again, our priorities for nursing are perfusion,